Welcome to Catch 11, the endovascular treatment of cardiovascular disease. This video is about the treatment of coronary artery disease, and I'm joined by three expert interventionalists from our area. On my left is Dr. Samir Pancholi, who's the program director for the Cardiology Fellowship of the Wright Center for Graduate Medical Education. And next to him is Dr. Kevin Olson, who's the director of the Cardiac Catheterization Lab at Community Medical Center. And on my right is Dr. Stephen Voice, who's the chief of cardiology at Moses Taylor Hospital. Welcome, gentlemen.
Thanks. Thank you.
So we're going to start out by talking about coronary artery disease. Steve, why is that such an important subject, and why are we concerned about that?
Well, the issues with coronary artery disease is that it's the #1 cause of death in the United States for both men and women. There's estimates of approximately 600,000 deaths per year due to cardiac disease, and about 750,000 acute myocardial infarctions every year, heart attacks every year. So it's an ongoing problem.
Well, Steve, women are concerned about breast cancer and other things like that. Coronary artery disease, they should be equally concerned about?
Far and away, coronary disease is the #1 cause of death in women in the United States of all races.
So there's been a remarkable evolution in the treatment of coronary artery disease. We've gone from medications alone to coronary bypass surgery to percutaneous catheter-based interventions. Kevin, you're the most experienced interventionalist in northeastern Pennsylvania. Can you give us some historical background on that?
Well, as you know, before 1968, pretty much we only had medicines to try to treat heart attacks and coronary artery disease, and then in 1968, bypass surgery became more prevalent. And then in 1977, Dr. Andreas Gronzek in Switzerland was the first to perform what we call angioplasty, or balloon technique, where we actually opened the blockage, and in those days it was still somewhat primitive. But over the years, the technology has become much more advanced to the point where in the 1990s we started to place stents in addition to balloon angioplasty, and that improved outcomes as both immediate and long-term. And then the stents have become more sophisticated, both in their deliverability as well as the drug-eluting stents that have made the outcomes even better. So the technology has expanded greatly over the years since 1977.
Right. And aren't there well over 1 million percutaneous catheter-based interventions on coronary arteries in the United States every year?
Yes, there's quite a bit. In fact, it's been on an upswing actually over the last few years to the chagrin somewhat of the surgeons, because what used to go to open heart surgery for bypasses are now actually being performed by interventionalists with angioplasty and stent placements.
Right. And Sam, we were just talking about the rapid evolution and the shift from PCI to CABG surgery. And nowadays, PCI outnumbers CABG surgery 5 or 6 to 1. Can you tell us about some of the latest innovations? Why has PCI become so successful?
Well, PCI is, obviously very minimally invasive, so to say. It does not involve an incision, and so all the healing issues are eliminated. We initially thought that the coronaries dictated the outcomes, which is certainly true, although we have learned in a very harsh way that the catheter-based procedures, because we puncture the artery to get in the body, also have a risk of bleeding, which is important. So lately what we have seen in the US especially is a tremendous growth of other access site, which is the wrist or the radial artery. So that's one of the American advance, so to say. The rest of the world has been practicing that way for a long time, but we have finally caught up. We've also had a lot of innovation in drug development, and there are some new blood thinners that we use now that clearly lower the risk of bleeding. So we are focusing on the bleeding aspect and other complications of catheter-based procedures, which have now made them a step further closer to better safety. And I think that's the cutting edge or state-of-the-art status of the procedure.
So just as in open heart surgery, where we've noticed that transfusion increases the chance of short-term complications as well as long-term complications, including death, that's been recapitulated in the PCI world.
Absolutely. Yeah, in fact, we initially used to feel that blood loss was a trade-off for an open coronary artery, and that as long as your coronary artery was open, you would do just as well. although we have found out that blood loss is an important variable and we should prevent it at any cost.
Right. And although it's technologically more demanding, the radial artery approach clearly results in fewer complications, especially bleeding complications.
Absolutely proven beyond doubt now. Yeah.
Steve, do you have any comment on that?
I think it's important that the devices are improving, as Dr. Olson was saying, and the techniques to minimize complications are improving, as Dr. Pantroli is saying. I mean, the bleeding that occurs during an intervention is a problem not only from the fact that you're bleeding and blood pressure may go down and folks may require a blood transfusion. Some of the very important blood thinning medicines that we need to keep those stents open tend to be stopped at that time. So there's an increased risk of the stent having problems, clotting up, et cetera. But we're all now beginning to understand that the blood transfusion itself may cause a lot of problems.
So that being said, radial artery approach having many advantages, femoral approach is not dead. In fact, it's still used in the majority of procedures in the United States. Kevin, you were one of the earlier adopters of bivalirudin, and that's been shown together with the femoral approach to minimize complications, hasn't it?
Yes, it was another type of platelet or blood thinner to help minimize clot formation, especially during angioplasties. And all of these new medicines that have come over the last 10, 20 years have greatly improved the outcome, both immediate as well as possibly under certain circumstances, long-term benefits for treating patients with coronary artery disease.
Now, you mentioned the rapid growth in PCI. You mentioned the use of stents in the 90s, and then we had drug-eluting stents coming on board in the 2000s, a little more than 10 years ago. Can you tell us about that and what's new with those stents? Why are they better?
Well, the stents that use the drugs tend to decrease the chance of a reblockage, especially in the first 6 months to a year. And if you use a bare metal stent, a stent that does not have any drug that's impregnated on it, you probably have about a 17% chance of a reblockage in the first 6 to 12 months versus maybe about 5% or even less, even with the second generation drug-eluting stents, depending on the type of patient. So we've reduced the need for revascularization from an angioplasty standpoint in the first 6 to 12 months with these newer stents.
Can you tell us what's the efficacy of PCI now in 2011? Where do we stand?
Dr. Pantroli mentioned it earlier, and coronary intervention really has been one of the leading techniques that have been studied in a comparative way, looking at the utility of angioplasty and or stenting versus medicines or versus things like bypass surgery. What's the best way to get the arteries open, keep them open, and then looking at not only that initial time, but how do the patients do? Do we decrease the risk of heart attacks? Do we decrease the risk of that patient dying from coronary artery disease? So there's been a number of head-to-head trials that look at angioplasty stenting versus bypass surgery, and it's evolved over time.
Right, and we probably don't have time to go over all the trials, but the latest one, the one that's getting the most attention, is the Syntax trial. And that was interesting because it had a couple of unique features. It was an all-comers trial. Some of the previous ones were selected groups. It required a heart team approach, and just like CATCH is about convergence, that's what Syntax required. They required an interventionalist and a surgeon to both look at the films and to agree that the patient could be treated by one or the other or both modalities. And finally, the contribution of Syntax was the Syntax score. They looked at how severe the coronary disease by giving it a score of the complexity of the disease. So, Sam, do you have any comments about the Syntax trial?
Syntax trial has basically retaught us the basic theme is that the modality of treatment should be chosen for a specific patient based on their status. The Syntax trial focused more on the anatomy or the status of the blockage burden. So if you have many blocked arteries, then you have a high Syntax score. If you have 1 or 2 blocked arteries, then you have a low Syntax score, and the location matters also. And if we apply that scoring system, we can properly triage patients to either angioplasty and stent or bypass surgery. Right. Now, I have to preface this by saying that not every patient with a blockage needs that blockage or blockages opened up. So we are now talking about patients who have been decided or chosen by their physicians to have something done to their blockages. Right. And in that subset, if you use the Syntax scoring system, you can give them the best modality of treatment.
So the reason we revascularize people, perhaps we should have pointed this out in the beginning, is to either relieve symptoms or to prolong life. So the Syntax was looking at folks who left main and 3-vessel disease, who have a pretty good idea from previous information that their life is going to be shortened without revascularization. So they found for patients with three vessel disease who had low syntax score, they did just as well with PCI as with CABG surgery. This was the first time this had really been demonstrated in the all-comers approach. Those with intermediate or high scores actually did better with CABG, especially the hard endpoints, death and MI. Revascularization rate is higher with PCI, but interventionalists like to point out that's no big deal. Am I right?
I think the take-home message from that study is what we knew 15, 20 years ago, is that triple vessel disease, the more disease, and especially with bad LV function, and left main disease usually did better with open heart surgery versus percutaneous interventions such as angioplasty. So I think if you look at some of the subgroups in that syntax trial, you can go either way depending on the individual patient, whether you were going to intervene, because you're going to trade maybe a higher incidence of stroke versus a revascularization procedure or another angioplasty in that first year. So, you know, it's an interesting study, but I don't know if it puts the rest totally which approach. That's why even the authors state it's somewhat a decision between the physician and the patient, depending on their preferences and potentially different outcomes.
I think this actually brings up a very important point from hearing you guys discuss this, is that the complications of these procedures are not really the complications of these procedures, they are the complications of the disease. And so at 3 years, whether the patient had a stent or a bypass, their stroke rates are quite comparable because the level of the disease is at a certain advanced level. And I think, you know, the disease burden is what dictates outcome. And we frequently refer to as somebody having a complication of their bypass operation. But in reality, that's the complication that that patient's body developed because of the extent of plaque burden that they had.
Plus the medicine intervention was argued that the angioplasty and stent group are going to receive 2 platelet inhibitors versus usually open heart patients, and was the medicine itself beneficial reducing early stroke rate versus vis-a-vis people who went to open heart surgery. So even the medicines we use as adjunctive management in our intervention sometimes affect outcome and in some ways very beneficial outcome.
Right, exactly. I think that's the important point, and you hit that, regardless of the mode of revascularization, you still need to treat the entirety of the body, all the blood vessels in the body with the appropriate medications, which in fact have been shown pretty definitively to increase life expectancy and decrease the risk of heart attacks and strokes. Those blood thinner platelet agents, as you said, cholesterol medicines, and so on. So revascularization is a very important part of it. But with a disease burden or the blood vessel blockage burden throughout the body, you need to approach that in a medical way as well.
So in the environment of less money to go around, we're probably facing serious Medicare cuts, and the increasing expense of healthcare is breaking the national back, so to speak. We're being asked to look at comparative effectiveness and cost effectiveness. So PCI being a good example, rapidly growing field. What's going on at the national level to scrutinize that in terms of its efficacy, particularly its cost effectiveness?
Well, I think there's a lot of emphasis from the third parties, Medicare, et cetera, governmental agencies looking at the utility of a procedure. And I think you're going to see this with many procedures, not just intervention, angioplasty. But really what is being looked at is what is the intervention being done for? Is it being done in an appropriate setting? I think what we want to see is that patients are treated optimally with their medicines up front, and this is for stable patients. Again, patients with acute heart attacks or unstable situations are a different ballgame. But those with stable disease, stable blockages, want to make sure that they're getting optimal medical treatment, blood thinning agents, cholesterol medicines, et cetera, that they're treated in a way to try and minimize their symptoms as best as possible, and that there's a reason for doing the procedure is really what folks are looking at. You know, is there evidence that that blockage is responsible for symptoms or can potentially cause a bad event in the future, and therefore fixing it by an intervention or by bypass surgery gives us some outcome benefit rather than just making the artery look better, making the blood flow better in the vessel. Do you have a patient that's going to potentially live longer, or you're decreasing the risk of heart attacks in that individual?
Sam, what do you think?
I think it's very important to realize for everybody, including patients, that the fact that the artery has a mechanical blockage does not automatically translate into the only treatment being unblocking. A blockage is mostly a chemical entity, and most of the bad outcomes related to a blockage are caused by abrupt chemical imbalance. Mechanical treatments, that is why, are not able to prolong life and change very hard outcomes in a big way in majority of these stable patients. So the chemical treatment, i.e. medical therapy, is of paramount importance, and that's a very legitimate way of treating a mechanically blocked artery without unblocking it. The unblocking procedures like angioplasty and stent or bypass surgery, which is a conduit to bypass the blockage, are important in certain circumstances, but it has to be individualized and properly applied in order to get the most out of it.
One thing just for the audience to make clear is there's no question that the use of angioplasty stents, especially, or at least unblocking an artery during a heart attack situation, has been shown to be the way to go. So we're not necessarily, the debate out there right now isn't necessarily about those patients. And most people might not know that roughly 50% of heart attacks occur in people who actually have blockages less than 50%. So the ones that we tend to unblock with angioplasty may not necessarily inhibit future heart attacks anyway, and that's where the medicine or chemical component comes in, as simple as an aspirin a day. That's why we use it prophylactically to try to decrease the chance of developing into a full-blown heart attack, or at least buy time so the patient can get to the hospital, and then we can intervene with angioplasty, with or without stents, to abort the heart attack. So there's been no argument there. I think the data and the studies have demonstrated over and over that angioplasty and stenting, and in the acute setting, has been extremely helpful. I think where we're seeing more focus and more studies is try to determine the patients who have more chronic disease and have multiple types of blockages, and whether or not some should be treated medically and others should be left alone even, or others should be opened up. And I think that's where you're going to see the trend, where we're trying to determine what's called the ischemic burden. We're trying to determine if these blockages are actually causing a problem for the patient and should undergo angioplasty, stenting, versus just medical therapy and even trying to do preventative therapy. Because if people don't modify their risk factors, including cigarette smoking, it really doesn't matter what we do, because these patients will block up, whether where we perform our procedures or elsewhere. So patients themselves and the community have to take responsibility somewhat for the development of their own disease.
I know you and all the cardiologists strongly emphasize primary and secondary prevention and modification of risk factors. So here's what I think I've heard so far today. Although there's continued improvement in the technological advances for PCI, it in and of itself may not prolong life except in an acute myocardial infarction. Medical therapy is still primary. They're very useful. We don't necessarily have to unblock every lesion. There may still be a role for CABG surgery, especially in those with severe and diffuse disease. The mortality of the patient over time is directed by their disease, not necessarily by the procedure that we choose up front. And the modality that we choose is dictated by the patient's circumstances. Steve, what about a look to the future? What do you see coming up for coronary artery disease, for PCI?
There's a number of things that are happening. Clearly, there's improvement in the medical therapy, better blood thinning agents that prevent clots better with more safety, less bleeding risk, better cholesterol medicines. But where the very big area of interest is some of the imaging technologies, trying to find these plaques that, as Dr. Olson said, maybe less than 50%, but are the ones that are at risk for future heart attacks. Imaging those in some way, be it by CT scan or MRI or some other perhaps intracoronary technique that'll direct us and perhaps direct therapy specifically towards that area. Further evolution in the stenting, better medications to decrease reblockage, better stents to get us to areas that we still can't get to. Getting across blockages, arteries that are totally blocked up still remains an area where our success rates aren't quite where we'd like to see them, and there's innovations going on in that realm.
Kevin, what do you see coming down the road?
Well, what do I see coming down the road? That's a good question. If I knew that, we'd all be rich here at this table. I think we're going to see more self-policing by the profession to try to use all of these new technologies and modalities in a responsible fashion, both for the patients as well as for our society, and trying to be as cost-effective, but also not jeopardize, of course, patient care. And it's not as simple, I think, as everybody would like to hear, especially if you listen to the news or watch TV. Everybody thinks everything is black and white. There's a lot of gray zones. But I think we're trying a concerted effort as physicians to become more responsible in using all these technologies in a way that the most people can benefit, yet we won't bankrupt the system. And having said that, I do think that the insurance companies and the middlemen and the third parties have to also take some responsibility and make sure they don't line their pockets with money that should be earmarked for patient care and the community in general. And I think that's one of the problems too. I think we need to evolve the business aspect of medicine so it doesn't interfere with what patients and physicians need to do to improve their lifestyle and their outcomes.
Sam, what do you see for the future for coronary artery disease and PCI?
I think, as we've already talked about, we are going to see tremendous improvements in technology, which includes the stenting and all the other, some of the stents that we're going to see, which will be absorbed by the body. And then we're also going to see, and we've already seen some improvement in the technique, which is the choice of how we get in the body. The radial artery has shown us that we can reduce complications. It takes a little bit of learning on the physician's part. So I think there's going to be a global continuing evolution in this field. I consider angioplasty and stenting in the medical field as a pilot project to evaluate how evidence-based practice works. From the outset of the birth of angioplasty in 1977, it has been continuously scrutinized and studied, and we have reached this point close to 40 years later, which is a very premium product and truly minimally invasive and ambulatory, so to say. So I think you'll see more of that. There's a lot of benefit to the patient in that innovation.
Well, it's
Where do you see surgery, Russ?
Well, it's certainly been a remarkable evolution. Surgery's not standing still either, although it's a mature procedure, coronary bypass grafting. We emphasize multiple arterial grafts, smaller incisions. It's sort of a no-brainer that the less you traumatize someone, the quicker they'll recover. We see hybrid procedures with internal mammary artery placed to the LAD and then PCI to the other vessels. Steve asked me earlier about robotics. It's not mature yet because it's expensive equipment and sometimes difficult to use. But I think less trauma is the name of the game for surgery. We have to catch up, if you will, to PCI. Well, this has been a great discussion. I want to thank Drs. Pancholi, Olson, and Voice for joining me. Thank you very much.